Hello there, my name's Ian Hamilton, and I just want to share some thoughts with you about addiction and the relationship between drugs, addiction, and mental health. I think the first thing to briefly say is how addiction is defined, and there are several different ways of defining addiction, but in essence, and put it at its simplest, addiction is the move to being in control, in effect, of how much you're drinking or how much you're using in the way of drugs like ecstasy or heroin or cannabis or whatever, to a position where you don't really have control. And that can be triggered by physical dependence and or psychological dependence. So one of the ways that we notice this clinically and in ourselves is that you begin to experience uncomfortable withdrawal symptoms in the absence of the drug or alcohol. So that's a relatively easy way to measure whether you have a physical dependence on a drug. Psychologically, a similar kind of thing would happen is that you would become preoccupied with using the drug, or in the absence of the drug, of trying to source it, of trying to feel a bit more comfortable mentally and psychologically. So I think many of you will be familiar with people who have problems with addiction, and really the focus of what I'd like to chat about briefly today is how that relates to mental health. And the kind of term that's used most commonly for this is dual diagnosis, which many people find is a difficult term, doesn't neatly capture really what's going on, but nonetheless it's one that has parlance within certainly services, health and social care services. So dual diagnosis just of course means there's two issues going on, but in this case we're looking at mental health and drug and alcohol problems. So I guess one of the problems with dual diagnosis is that in my time working as a clinician and a researcher, is it's kind of moved in terms of what it means and what most people apply it to. So when I started 30 years ago as a psychiatric nurse, really what we were talking about with dual diagnosis was people with very severe mental health problems such as schizophrenia or bipolar, and using drugs pretty problematically or chaotically. But what I've noticed over the last 3 decades is that the people that dual diagnosis captures has broadened out. So in addition to people with severe mental health problems using crack or cannabis or whatever, it now seems to encompass people who might have things like social anxiety and use alcohol to mitigate that and to cope with that. So it's a much broader group of people that we think about. In terms of prevalence and incidence of dual diagnosis, because it is such a wide group, it can be quite variable in terms of what the research says about how common dual diagnosis is. But I think most people, the kind of most popular view is that really for people with a mental health problem, using drugs and alcohol in a way that's unhelpful is the norm rather than the exception. And likewise, in drug and alcohol services, it's not uncommon to meet people who also have a coexisting mental health problem, whether that's anxiety, depression, or something a bit more serious and enduring. So for both groups of workers, those in mental health, those in drug and alcohol services, there's a lot of crossover in terms of the problems people present with, and we shouldn't be surprised by that. Despite services being organised in this parallel way, that's not the way people live their lives or experience problems when they happen. It's one individual with at least both those problems going on, in addition to a whole range of perhaps social issues around housing, money, relationships, etc. Now, unlike mental health, so let's say for depression, where there are some very clear and psychometrically sound instruments for assessing depression, and those are kind of universally agreed, for dual diagnosis, we don't really have a psychometrically sound instrument. So there is no one instrument that I can recommend to you that is used in the assessment of people who have mental health problems and drug and alcohol problems. So I don't think we should be surprised by that, given that mental health on its own in a kind of global way, is quite challenging to assess. If you then add drugs and alcohol into the picture, you can see that the assessment would be quite long and laborious. And it's unlikely for people who have acute problems, they would be able to stay with you as an assessor long enough to go through all the different variables that need to be checked. So quite often what I hear teams and individuals doing is asking questions or orientating the assessment around ideas they have and probably tailored to the client group that they're seeing. So, and again, we shouldn't be surprised that there is no dual diagnosis assessment, given that we can't even do a head count accurately of the number of people who have this issue. So and a lot of that's to do with the setting that you work in or that you come across people. So whether that's an acute inpatient area, community setting, etc., it's going to vary a bit in terms of the exact number of people who have this issue. I think the other thing I found makes assessment quite tricky is that we know that cognitive function is adversely affected when people have things like depression and anxiety. And also that can varies in terms of things like memory, ability to problem solve, concentration, all the kind of facets of cognitive functioning. If we then add in drugs, in psychoactive drugs into the equation, including alcohol, we know that those also affect cognitive functioning, although that's not always necessarily in a negative way, but it can be once people get to the point of becoming dependent or at least having problems with their relationship with drugs and alcohol. So that's another aspect that makes not only assessment challenging and difficult, but also interventions. We've got to think about the pace at which we go when we're doing even talking to people, and it's not that people are lacking intelligence, it's just their cognitive function may be impaired. So that means we may need to repeat things, to check understanding, to go at a slightly fairer pace so the person can stay with you in terms of the conversation and what it is you're trying to understand. So it kind of gets you thinking, doesn't it? Why would people with a mental health problem be using drugs and alcohol? And Lindsay Gregg over at Manchester has done some amazing work on this, trying to understand this very question: why is it people with a mental health problem use drugs and alcohol? And clearly, when you ask people who have a dual diagnosis why they're using drugs and alcohol, the answers you're going to get are based on their experience, and so therefore they're subjective and to do with their perspective. But I think they offer a really useful insight. And what Lindsay Gregg found was that, no great shock and surprise, people with a dual diagnosis use drugs and alcohol for the same reasons you and I do, and that's for pleasure, or to have a good time, or to celebrate. So it's not to mitigate the symptoms of their depression and anxiety. Now this is where we get a mismatch, because people with a dual diagnosis are saying they use drugs and alcohol for pleasure. Now that's in contrast, quite stark contrast, to what most workers believe. So most workers, when they're asked the same question, would view that people self-medicating in effect. So that's the reason workers give for people who have depression and anxiety using drugs and alcohol. So there's a mismatch there between the perspective of patients or clients and what staff are saying. So that's quite an important thing to understand, and obviously has an influence on the conversations that you might have with people. There's a clear difference starting a conversation as a worker from the point of view this person is using to negate symptoms of mental health by using drugs and alcohol, as opposed to thinking, right, this person's using because they want to have a good time and it's something that's pleasurable. So I think that's something really important to think about as a worker in this area. Now, self-medication as a theory is something that's been with us for 20 or 30 years, and not everybody's convinced by this idea that people who, let's say, have a problem with their mood find that using alcohol or using stimulant, for example, like amphetamine, is a way of them feeling better. So and originally, Kantian's study on self-medication was really around the way people who use heroin were using that to cope with the way they were feeling and improve the way they were feeling. I personally think there is some traction and some utility in thinking about self-medication as a theory, and in my experience in practice, I've certainly met plenty of people who, in my view, I think are trying to, as I say, mitigate those feelings that they have and those emotions they have. And, you know, I've got to be honest with this. I think that drugs work extremely well in doing that. They don't work terribly well in the long term, but I can understand why people have tried to find solutions to their own problems and found that they work as well. I think one of the problems we have in terms of the systems of care that we currently have and have had for a good while is that unfortunately they're disintegrated rather than integrated. So we still have funding, commissioning and provision of treatment that basically follows parallel tracks. So we have distinct mental health services and distinct drug and alcohol services. And as I say, you know, many people will have both problems. So at the very least, what they're having to do is to be in touch with two services, navigate the way around that. And at its best, what we see is workers from either service working closely together with the individual. Now, unfortunately, the research and the evidence on integrated care has still to kind of be established. And Gillian Haddock and colleagues over at Manchester published a study back in 2010 in the BMJ looking at providing a combination of things like motivational interviewing, cognitive behavioural therapy and family work in an integrated way for people predominantly with schizophrenia, but also using cannabis, alcohol and other drugs. And they couldn't find any evidence that integrated care to that group of clients provided superior outcomes. But that's not to say that the evidence should stop us from trying to provide integrated care. It's just the evidence so far hasn't been able to show, as I say, some positive outcomes. But most workers I meet, most clients I meet, despite the lack of evidence, would say they would prefer to provide and receive integrated care. I think the other thing that struck me is the where clients identify themselves in terms of mental health and addiction. And I'm still not terribly sure about that. So the stigma for both areas, you know, mental health in itself carries a stigma, so does problematic drug use. And what I'm intrigued about is where do clients see themselves? Do they see them, you know, when they have a mental health problem and a drug and alcohol problem, providing they're aware of that, where do they identify themselves? Do they see themselves belonging to the mental health community or to the drug and alcohol community, or perhaps neither? So I think that's still something we've got to explore, got to understand, and again, I think we'd offer some really valuable insights for the way that we approach people with interventions and trying to engage them in services with the aim of improving their lives and eventually getting into recovery. I think we still have a problem though, if I could be so blunt, and just suggest that although wider society stigmatises these groups, I still think we have an internal problem in staff attitudes towards people with a dual diagnosis. So I'm aware not everybody views clients like this, but I think we still have a significant problem with a group of staff. So for instance, in some mental health staff, I think can label people who use drugs and alcohol as being deficient, as bringing the problems on themselves, for example, and I think that influences the type of care these people receive, and the attitudes leak out to those clients who I think pick up on that. Flipping it around, I think for people working in the drug and alcohol sector, I think there can be problems like real fear and lack of confidence around dealing with kind of very, very frequent we've seen problems, things like depression and anxiety. And that's something we can work with, improving the confidence of those staff to feel as though they can offer something rather than feeling we have to refer on to mental health services as an area I think we should be aiming to work on and invest in those staff. I think lastly, the thought I'd like to leave you with is where we've come from over the last 20 or 30 years. And I think where we've ended up is it is beginning to change, but I think we've got some conflicting philosophies on the go. So what I've seen over the last 2-3 decades with mental health is a move away from thinking and organising services where the person is essentially responsible for turning up to appointments to receive care and treatment for their mental health, to a much more assertive outreach approach from staff and teams that provide mental health care. So we have, as you know, assertive outreach teams, crisis resolution teams, and other community teams that actively go out and seek to engage people in the mental health system. Now that's in stark contrast to what's been going on in addiction, where the kind of prevailing philosophy has been one of come and see us when you're ready to receive treatment and almost admit that you've got a problem. So that kind of sets up a very clear kind of juxtaposition between both services. So in mental health, there's kind of a quite parental approach where people are actively sought out and brought into services, compared to addiction where you're treated as an adult and it's up to you to seek and get treatment at a time when you feel ready to do that. So I think for someone who's got both problems, at best that can be confusing, and I'd like to see a much more joined up way of thinking in providing treatment for people, let's say, who have depression and also are dependent on alcohol. So that's just some brief thoughts around dual diagnosis. I hope they're useful, and I'd be happy to and really keen to hear your views on all of this. But bye for now. Thank you.